What's up, everyone? Today we're going to talk to you a little bit about cervical spine assessment and then what are some treatment options. Now, of course, before you do any of these techniques, you want to make sure that you talk to your physician or your therapist or whoever that you go to see, that wherever you are in the world, that gives you that access to be able to do that before undergoing or performing any of these techniques. This video is for entertainment purposes only, of course. Now, with that being said, the things that I look at, with cervical spine, we can really get bogged down. And for several years, I looked at a lot of just very, very specific, palpation assessment type things. I relied so much on special testing, which I still do both of those things. But I think one of the things that really works the best for me is I like to take a good history, see, what has been going on with the patient, prior to their complaints, and then of course what mechanism or etiology that's causing them, and then go from there. And then I want to watch them move. I like to watch the patient move, even when they're in and we're just kind of talking, kind of in an interview type situation before we get into the full out evaluation portion. Then I'm watching the patient's head movement. Do they have a preference of does their head lean or a certain side? Is their head forward? Is it back? Do I notice them keep turning, maybe trying to pop their neck or performing some range of motion stuff? So I'm looking at all those things while I'm going through the process of the interview and the evaluation. Now, the question that's asked is, okay, if I see them deviating to one side more than the other side, is that going to drastically change how I treat the patient? Not necessarily, because I think if you look at a lot of research, then you're going to find that a lot of things, generally speaking, can have an effect on neck pain, neck range of motion, and the overall functional outcome of the patient. So I don't think it has to be just my preference as specific. I'm not looking to see exactly if there's a rotational component or something that's really looks like it's missing and I need to do a mobilization in that area, or depending on where you are in the world, if you can do manipulations or whatever your profession is or whatever, then I don't necessarily carry or hold a lot of value in that specifically. Now, that's just me. Now, I know that a lot of clinicians do, and that's fine, and I admire those folks because that's a lot of information to know and a great skill set to have, and you have to be pretty skilled, I think, to be able to do that very well. So anyway, so that's just kind of a preface to kind of what we're going to be doing. So the things I'm looking at when the patient comes in, the things I want to know is location of pain. Now, if you're at home and you're not going to go to therapy or go to a medical provider, or you've went, let's say that you've went and now they said, well, go home and just try some things, look some stuff up on the internet, and you come across my channel, hopefully, and what can you do? What are some recommendations? And so the things you need to know is location of pain. Where does it hurt? Is this pain in the front side of the neck, in the throat area? Is this pain on the back side? Does it radiate down the arm into the hand and fingers? Does it come around the shoulder blades? You have pain in that area, numbness, burning. Do you have pain on the side of the head or jaw? Is it unilateral? Is it on one side or is it on both sides? Just kind of just some general information with that to know where the location is, where's the primary place that it hurts. And that's what I'd ask a patient when they come in and say, point to the spot that hurts the worst. And if they say, well, I can't really pinpoint it, it just kind of radiates all around, that's, kind of already telling me some things that's going to lead to further testing that I'm going to do. Then what are the provocating symptoms or provocating things that increase the pain, right? So is this if they go into extension, if they go into forward neck flexion, if they turn and look over one shoulder or the other, does that increase the pain? Is it affected by sunlight? If maybe this is a sort of visual issue that's causing a headache, and then they associate the headache with neck pain, or maybe they start to have a headache, and because of the pain of a headache or a migraine or something like that, they start to have tension in the neck, and that causes the neck pain. So I'm looking at all these things together because it's all so related, and especially for the patient, spending time with them and really getting to learn all these things and know this about them, I think that they trust you more, right? And the more that you know what you need to be doing. And so a lot of times when I get patients, my evaluations can be a little lengthy because, well, one, because I like to talk, and two is because I also listen a lot, to the patient. So I'm listening to everything, their story, like what happened, what caused all this, etc. Because a lot of times, in the medical community, we're so, especially if you're insurance model based, it's so high paced. You have to see so many patients, and it's very difficult to do, and so it's hard to find that time. But I'm always, when it comes to evaluation, I want to make sure I carve out that time, make that time for the patient to go through everything. So I'm looking at, again, provocating movements. I would do a repeated motion exam, have them go into extension. Maybe I do 10 to 15 repetitions, or cervical retraction. We do retractions. We do cervical forward flexion, cervical rotation, side bending, and then I'm going to also do this with overpressure. So I would have them go through the movements without the overpressure, without me loading through those vertebrae, and then I'm going to load through the vertebrae manually. And I would do this in sitting position and in usually supine. I do both. Because you say, well, why am I loading? I just want to see how the body responds, or how they respond when that additional load is going through. There's already load going through it, right? The weight of the head plus gravity and all that's kind of coming in, but just that extra pressure just to see kind of what happens. And then we're going to look at, again, radicular symptoms. Is this radiating symptoms down the arm, into the hand and fingers? I'm going to go through the cluster of Wiener. I would do those tests to try to check to see for a true cervical radiculopathy. Is this a situation where we've got some trigger points or some areas of heightened sensitivity that's causing referral pain down the arm? Is this a rotator cuff issue, that especially the supraspinatus there will cause some issues and can radiate down the arm and radiate up to the neck? Is it something with that? So to try to, either rule that out or rule that in, I'm going to go through several of these tests. So and some of the tests that I like to use too may not have high sensitivity and specificity, although the cluster of Wiener has very good specificity with that. But I'm going to do additional tests because I feel like whenever you're doing these testing, it doesn't take that much time to throw in a few extra tests. Even if they're not that great, I still throw them in because let's see where these the cluster of positives or negatives kind of fall. Are they gathered up more in this direction? Then I would lean more this way, or more over here. I would go this way. And if you get something that's just way off the wall, then I would just consider that an outlier, and it would be, wouldn't really have any clinical value. So I would do that. I would do the Valsalva test just to check to see if I'm putting that abdominal pressure in there. It pushes against the front of the vertebrae, and just to check to see if that reproduces their symptoms. I like that test a little better for the lumbar spine, but I will use it for cervical spine as well. And then we're looking at, I would do like the Hoffman's reflex just to see if there's an upper motor neuron lesion. So I'm going to do that. Reflexive testing, dermatome testing. We're going to do those things as well. I also use handheld dynamometers. So I'm going to measure, muscle strength with a handheld dynamometer, and I use electronic goniometers as well, or I use the regular goniometer. I still have both, so I would use both of those just to get an idea of some objective numbers, especially if it's an insurance company. They want to see some of these objective numbers. So I would do it for that purpose. I don't think that it necessarily matters, in my opinion, if you've got 60 degrees of cervical extension versus 65 degrees or something like that. I don't think that's going to make that big of a difference. Obviously, something like 20 degrees versus 80 degrees, would be a big difference. But I'm not looking for small, increments there. I don't think that's all that relevant in the grand scheme of everything. So I would do that. The next thing we're going to go through, again, is a movement check. And so I like the SFMA, Selective Functional Movement Assessment. I think that's an easy and quick way to screen movement and assess movement. So I would go through that. I would look at flexion, extension, rotation, side bending, and then thoracolumbar, the whole area. I'm going to look at that multi-segmental rotation of the thoracic spine, because we know there's some contribution there with cervical rotation from the thoracic spine. Not just a ton, but there is some research out there that does support that you're going to have some contribution from the upper thoracic spine. So I would check that and just kind of see how they move. Do they deviate to one side versus the other? When they forward flex, all the segments look like they flex symmetrical, or there's some kind of flattened out areas that don't look like they're flexing appropriately, and that could be a stability motor control problem. So that's kind of gets into our path of treatment on down the line. And then we're going to look at passive assessment, and palpation. So I think probably with the palpation part, for a lot of clinicians, there's always this pendulum that swings and this big argument side to side. You're exercise-based, movement-based only therapists, and I say only, but predominantly, are going to go over here like, well, motion palpation or all this stuff is not that effective, not that accurate. It has poor reliability. And you're going to have your hardcore manual therapy folks over here that use their hands all day, every day. They're going to argue against, well, you can't do these exercises without doing some manual therapy work, et cetera, or to feel manually what's going on. So I don't necessarily have a preference either way with that. I think you could do. I think it goes either way. Like whichever one you like to do more or better, do whatever. I like to do both, so I just do both. I think both is great. So I'm going to do that both in sitting and then also supine or prone. I'm going to go through, supine. We're going to check, cervical side glide. We're going to check a flexion rotation test. I'm going to apply overpressure with passive movement just to see what that looks like. And then I'm also going to look at, put them in prone. We're going to do, some P to A assessment, just to kind of see if it feels like something maybe stuck or doesn't feel like it's moving like it should. Again, this can be very difficult on someone that has a lot of muscle mass, or if they're a little, bigger, have a little more adipose tissue, that can be difficult to palpate. And so you just got to do the best that you can with that. And I'm just looking for me, things that really stand out. Now, I'm certified in manual therapy and orthopedic manual therapy, several certifications in that I hold. And you go through this pretty rigorous process and all this, and it's really kind of crazy because like a lot of us, sometimes you really feel some things, right? You can really feel that, and other times you're thinking, I don't know if I can feel anything here or not. I'm kind of guessing at it, right? Of course, you try not to guess, but I mean it's just what the research supports. It's just very difficult to be very pinpoint accurate with that. So then I'm going to go through that aspect. So it's kind of those 5 things I'm looking at. Location of pain. Provocating symptoms, are there radicular symptoms? I'm looking at a movement check, a movement assessment, and then we're looking at palpation, passive movement kind of stuff. I'm looking at all of those things, and then I'm going to go into my treatment. So to keep this really simple, and the way I even like to teach new clinicians or therapy students, like don't overcomplicate this stuff any more than you have to, right? Because you don't have time to get, again, in most cases, especially in an insurance-driven model, super bogged down in trying to figure out, let me go pull my home exercises and all these different things out, which I'll get into home exercises. That's kind of, a little later on in the video. But I like to go kind of 3 paths, treatment path A, B, or C. So A, and again, this is not an all-inclusive, this is generally speaking, right? So A is going to be for like a stenosis issue or a facet irritation or a nerve root irritation. I kind of clump those together. And then B is going to be more of a disc pathology. So you've got a protruding disc or a herniated disc or something like that. And then C is going to be more like soft tissue related, muscle spasm related, something in that area. Now, I know there's other conditions. Again, let's just kind of give you these 3 tracks to go through to try to pull apart and see what you're going to do for treatment, because some of the exercises do vary, right? And if you have someone that has, for instance, a bulging disc or a herniated disc in the cervical spine, a lot of forward flexion may irritate that and push that disc out a little more and touch the nerve root, or et cetera, whatever kind of approach you want to take with that. But that may aggravate and irritate the symptoms. And so you want to make sure that you're kind of at least going in the correct direction with that before, before you irritate it or something like that. So what we're going to do is we're going to go through the different exercises and the assessments for each of these kind of things we talked about, each of these stages. In the upcoming videos will be clips of going through each one of those from start to finish, so you can really see just a general aspect of how I would approach this patient coming in with this general neck pain. Again, this doesn't include like neck surgeries and some other complicated things, fractures and these different things. This is just generally speaking, kind of going towards those 3 categories or treatment paths that I talked about just briefly. Now, when we have symptoms that are going down the arm, or to check for ridiculous symptoms in the arm and hand, this is kind of what I would do. We're going to do the cluster Winter, which has the distraction, traction test, Sperling's test, upper limb tension test, and a rotation test. So we'll do those 4 tests. And then I'm going to come over here. I'm going to do a Valsalva maneuver. I'm going to do a Hoffman's sign or reflex there. We're going to check tendon reflexes of the upper extremity. We're going to check myotomes and dermatomes. And then also I like to throw in a cervical compression test. Now I know that we're already doing a Sperling's test, but I do like to just put in that cervical compression test just to kind of see what that shows there. And I would do these tests, and if there were no radicular symptoms that's going on, then we would go maybe just something more localized. This could just be an irritated facet, although I have seen irritated facets refer pain, around. So, but you would generally think that it would be more localized within the soft tissue of the neck, something going on there, versus, being something radiating down the arm. Could have an irritated facet joint, like I said, or one that's just not moving correctly. We've got to do some manipulation or immobilization or some sort of cervical reset in that area to kind of to reprogram everything. So you would do that. But this is my kind of go-to radicular symptom kind of guide and checks. I would go through these as well. And I have videos on all of these on my channel already, but we'll go through these in the upcoming video. So now looking at provocating movements as far as during a repeated motion exam. Kind of written this out here where repeated motion exam, also known as RME. So if you see that abbreviated throughout the video, RME, that's what it stands for. And so I'm looking at flexion, extension, rotation both to the left and the right, lateral flexion left and right. I also will look at for a head nod. So I would have the patient rotate their head and then go through a head nod. Should have about 10 degrees, give or take. I will look at that as well. But generally speaking, these 4 movements is what I'm looking for. And I would repeat maybe 10 to 30 repetitions. As far as the repetitions, that's just really my preference. I will go through these repetitions, make sure they're doing them as far as they can to the most in range of motion that they have. And then I'm looking to see, does this increase their pain, eliminate their pain, decrease their pain, or doesn't change? And so based off of that, I'm just looking to see which one of these movements either aggravates it. For example, if this was a stenosis issue or a facet irritation, repeated cervical extension theoretically would increase their pain symptoms. And then, for instance, then if it were a disc issue, repeated forward flexion at in ranges may increase the symptoms, maybe going down their arm, the radicular symptoms, because that may cause the disc to compress the nervous tissue. So I'm just looking at that, going to the most, the in-range motion that they have. And I ask the patient, just do as much as you can, go as far as you can, and then let's just see, kind of what we got there. So I do that, and so that would be my repeated motion exam that we're going to demonstrate going through just kind of what that looks like in the upcoming video. So we're going to show you the cluster of Wehner, which consists of 4 parts. So the first thing we're going to do is a Sperling's test. I'm going to bend Kinsley's neck over to the left side, put in a little bit of extension, and then I'm going to apply overpressure straight down. I'm looking to see if that recreates her symptoms or exacerbates her symptoms down the arm of the side that I'm bending her head or neck towards. And I'll repeat that to the other side. The next thing I'm going to do is the traction distraction test. I'm going to go underneath here. You can do this with a patient lying in supine, or you can do it in sitting. I'm just going to pull up, and you can do this several different ways. You can grab both sides of the head here and pull up, and I'm going to see if that eliminates the symptoms that she has going down her arm and hand. She has to actively be having those symptoms in order for that test to be able to be conducted. Then we're going to do an upper limb tension test. So I'm going to bring her arm here, depress her shoulder a little bit, pull her hands back, and go just like this, and see if that reproduces. I like to do it a couple of different ways there, just to see if that reproduces the symptoms into her arm and hand. And then lastly, we're going to do a rotation test. So I'm going to have her look over her left shoulder as far as she can, and then her right shoulder as far as she can. And what I'm trying to see here is whichever direction she looks, if her symptoms increase or reoccur on that side of the arm and hand, that test would be positive. And then again, I also like to perform the Valsalva test, cervical compression test. I'm going to do dermatome testing, myotome testing, as well as tendon reflex testing. And I like to just put those in just to double check. And also we do a Hoffman's reflex sign to see if that's positive for an upper motor neuron lesion. Another key part of the assessment is going to be range of motion and muscle testing. And so for range of motion testing, you can use just your traditional goniometer. You can use electronic goniometers. I use both, or inclinometers. And I'm going to measure here. We're just going to show extension. So, and then look all the way up for me, Kinsley. And I'm just going to measure this, you know, with goniometric measurement like we all learned in school, right? And so I would do goniometric measurements. I'm also going to check grip strength. I use just a handheld dynamometer. This one's electric. I have all different kinds. I always would compare both sides just to make sure that we don't have any significant, you know, weakness in one side versus the other. And then I also use this Lafayette handheld dynamometer. I like that. I put that on the side of the head. We'd go lateral, flexion, rotation, flexion, extension, you know, etc. to test that. And then we're also going to look at range of motion from the SFMA, what's called UE1 and UE2, being able to put your hand behind your back here and touch a landmark and then go behind your back, and there's a landmark for that also. I have a separate video on that, but I like to do that just to kind of clear the upper extremities. And then we also perform the multi-segmental rotation test, which we have a video on that for the thoracic spine. And I say thoracic and lumbar kind of grouped together just to kind of see if there's any rotational deficits there. We're now going to do parts of the selective functional movement assessment. So what Kinsley's going to do is look up as far as she can going into extension. I'm looking to see if that looks symmetrical, what this angle looks like as far as how many degrees from being, you know, parallel here. And then she's going to come down and chin to chest. We're looking for the bony portion of the chin touching the chest. Does everything look like it folds down nice and symmetrical? And then we're going to have her look back straight ahead. She's going to turn and look over her right shoulder as far as she can, and then her left shoulder as far as she can. And then look straight ahead again, and we're going to do side bending, right ear to right shoulder, and then left ear to left shoulder. And we're looking to see if these movements are either functional or dysfunctional, which is termed either F or D, and then painful, which would be P, or non-painful, which would be N. So for example, it would be DP, DN, FP, FN. And if the patient complains of any pain at all, even the slightest amount of pain or discomfort, I'm going to term that as painful. And so that's how we run through, you know, that portion of the SFMA. So now we're going to look at our passive range of motion and our soft tissue assessment. So we have Kinsley in supine here. I'm going to come underneath her neck. I'm just going to kind of do a side glide assessment just to kind of see what that side glide is. I'm going to also take her through passive range of motion and flexion, flexion rotation, which we know that also can be the flexion rotation test for cervicogenic dysfunction. I'm just kind of feeling here. I'm going to go on each side of her vertebrae there on the articular pillars and just kind of playing with that a little bit just to kind of see what kind of range of motion I feel, if I feel any kind of, you know, kind of very obvious restrictions. Because like I said before, it's very difficult with motion palpation to be very, very specific, at least it is for me. And then I'm going to also, you know, kind of lock her up like we're going to mobilize or manipulate here, just kind of feel, go all the way down the segments there and all the way up, and I'd go the other way. The same thing, just kind of checking all those areas. I'm going to do a P to A in this position. I'll also do it with her in prone, but just kind of feeling here. So I'm going through that just to kind of feel. And a lot of times when I already have the patient in this position, I'll do another test called a deep neck flexor endurance test. So we're going to bring her chin in. She's going to tuck her chin in a little bit. And then she's going to bring her head up and try to hold it there just enough where I can put my hands under her head. And I'm trying to get her to hold that for around 30 seconds or so, and you can relax. And so there's some guidelines on that as to how long male versus female should be able to hold that. And again, I've done a video on that, very specific before, but there's just a rough idea to see what her neck flexor endurance is. And I also forgot to mention that I would do overpressure. So I'm going to go passively while I apply overpressure in all different directions there, just to also see if that, you know, provocated her pain or reproduced her symptoms. Now in this position, we're going to look also again at some passive movement. So I'm going to go down here to the vertebrae, do a little bit of P to A, kind of working all the way down. Again, looking for something very obvious. I also would check rib springing. So I'd come in here, we just check the ribs a little bit just to kind of see what that looks like, because again, we know upper thoracic spine does have a contribution to cervical rotation, as well as when we're going to reach overhead, raise our arms overhead, we know that the thoracic spine has to go into some extension. So I would just kind of check that. I may have her prop up on her elbows, prone on elbows or something, just to kind of see what this looks like. But that's not always. And a lot of the patients, if they're in a lot of pain, they may not be able to get into this position, so I may not do this in this position. I may have done some of this in supine or in sitting as best that I can. So we're going to say, based off of your assessment, that you found that she either has a stenosis issue or maybe something with the facet joints. So we're going to show you 4 techniques that you can do to try to improve your symptoms. So the first thing she's going to do is going to be what's called neck roll-ups. And so she's going to lie on her back here. This needs to be very controlled. And so she's just going to work on kind of rolling her head and neck up, just almost like feeling each spinal segment roll as she comes up. She's going to try to hold that 2 or 3 seconds, and she's going to roll back down. And again, she's rolling up, starting from the bottom and rolling up and coming all the way up and then back down. And she'd repeat that maybe 5 to 10 repetitions, just depends on how sensitive everything is, for a few sets. Then in this position, she's going to also do what's called isometric. So what she's doing now is pushing her head straight back into the mat, and she's holding that, working towards maybe 5 to 10 seconds for 3 to 5 repetitions. Then she has her hands on her forehead and she's trying to bring her head forwards. And so this is an isometric contraction for cervical flexion. No real movements going on, minimal movement, but more of a muscle contraction. And now she's going to sit. We're going to go through what's called scap squeezes. So she's going to take this band, let her take this band here, and she's going to hold it. We're really focused on squeezing those shoulder blades together. She's squeezing them together. She's going to hold that a few seconds and then come back out. And she's going to repeat somewhere between 10 to 15 repetitions for 2 to 3 sets. And then lastly, what we're going to do is a little bit of what I call pillowcase traction. So you can buy at-home traction devices. If you don't have one of those, or you can't get one, this works really well. She's just taking a pillowcase, going right up in the base of her occiput there, right at the top of the neck where the skull kind of meets, and she's pulling up through her eyes, kind of at this angle. And so she's going to pull straight up, and she's going to hold that and just kind of breathe through it. Hold that for a few seconds and then relax. If this is difficult because of radicular symptoms down the arm, the hand, you may have to modify how you're doing this. You may have to lie down and do this, or if you have someone that can help you at home with this, there are other versions of this. We do have other videos on how to do this, but that would be what's called pillowcase traction. Now we're going to say, based off your assessment, you come up with a disc pathology. Maybe it's a herniated disc or something going on there. And so basically you're going to do the same techniques that you use for that stenosis and facet irritation, the same movements with one exception. You're not going to do that cervical neck roll up. What you're going to do is a seated retraction with extension and a little bit of overpressure. So just pushing on just above your lip, pushing straight back while kind of looking up just a little bit. That can be very uncomfortable combining that retraction with extension. So maybe at first, just work on extension, looking up, keeping that nice, slow, and control, and then start adding that overpressure where you push back. So that's the only difference that I would do for something at home between those two techniques. And there are a whole bunch of exercises and other techniques that you can use. However, to keep this simple for the video, things you can do at home, that's the easiest way we know to do it. And now for our third diagnosis category is going to be soft tissue related or muscle spasms or trigger points. So here's 3 techniques we're going to show you with this. The first thing that Kenzie's going to do is a scapular retraction. So she's squeezing her shoulder blades together, kind of depressing everything here and retracting her cervical spine at the same time. And she's going to work on this somewhere between 10 to 15 repetitions, holding each repetition for maybe 2 to 5 seconds. And then after that, we're going to show you, I've done this video before using a tennis ball. And so you can use a tennis ball. This is a acupuncture or acupressure ball. You can use myofascial balls. And so she's going to roll this up. And then she's going to throw this over her shoulder, and those areas back there are tight or that bother her. And then she's just going to pull in and hold pressure. Just kind of breathe through it. That kind of hurt so good kind of sensation. So find the sensitive area and then hold that pressure, just as long as you can throughout the day. Lastly, what she's going to do is what's called a suboccipital release. So she's just going to lie on her back, and same thing, has this ball right there, and just relax, and she's just lying on the ball. Now, if it's more on one side versus the other, this is going to work great. And you say, well, what if it's right in the center or if it's on both sides? She can take the ball out. She can take the pillowcase or towel, whatever she's using, roll that up, roll it up, and then she can put it just underneath her neck right where the base of the skull meets in that suboccipital area, and just relax and breathe through that. She may stay in this position 10 minutes, 15 minutes, just whatever she has time for, just to try to get this to relax. Thanks so much for watching this video. I hope that this helps give you an idea of kind of how to approach a cervical spine issue when related to just general pain. And either you're at home looking at this, you can get an idea of kind of how to run through some of these, and then some very basic treatments that you can do to keep it simple, to go through these things to try to give you some relief. So thank you so much for watching.